So Anne, could you explain to us what your job is and what your role in Leakin is?
I'm a consultant clinical scientist and clinical lead for clinical biochemistry at University College London Hospitals, and I'm the clinical biochemistry lead within Leakin, and I also sit on the acute kidney injury detection work stream for Think Kidneys.
So Anne, how is AKI biochemically defined?
We define AKI as a rise in serum creatinine from the previous value within 48 hours of at least 26 micromoles per litre, or 50% or greater rise in creatinine within the previous 7 days, or that we presume has occurred within the previous 7 days, since often it may be some weeks or months since the creatinine was last measured.
So Anne, what is the NHS England Renal Registry AKI detection algorithm?
This is an electronic programme embedded in laboratory IT systems that compares the patient's current creatinine with their previous value. If the definition of AKI has been breached, then it automatically appends a comment to the result warning of possible AKI and of the stage of AKI, be it stage 1, 2 or 3, is appended to the patient's result.
What are the requirements of the National Patient Safety Alert on detection of acute kidney injury?
The Patient Safety Alert was issued in June 2014 and required all laboratories to have the algorithm embedded in their systems by March 2015. And it also required thereafter laboratories to return data to the Renal Registry every month on patients who've triggered an alert.
What are the requirements of the Renal Registry return that's furnishing the master data set?
The return each month should include patient demographics and identifiers, the date the AKI alert was issued, the stage of AKI, and the creatinine and EGFR results at the time of the alert, together with previous serum creatinine results for the patient within the previous 15 months.
So if the Trust Biochemistry leads or IM&T leads need more advice about returning this data set, where might they get it?
Yeah, the best places to source that information is to go to the Think Kidneys website that has lots of information on it about how to compile the return, or to contact the Renal Registry directly, who will send you an information pack.
And what are the challenges of implementing this algorithm?
Well, I think the challenges have been several-fold. Firstly, for many laboratory systems, the electronic algorithm wasn't actually available by the March 2015 deadline, so that has led to delays. Once the algorithm is available, it does require quite a lot of time-consuming verification that it performs correctly within that individual laboratory IT system. And also that it doesn't have unforeseen consequences on other parts of the operation of the laboratory IT system. We've had a few instances of that reported where people have had to go back and implement other alterations to the programme to prevent unforeseen consequences. And then a number of laboratories have quite old laboratory IT systems that are actually unable to take the algorithm in its current form, so they're going to have to update their IT systems before they can implement. And of course all of this takes quite a considerable amount of laboratory scientists and IT specialists' time to sort it out and implement.
So Anne, if you're a biochemist in London or elsewhere and you wanted to get further information from colleagues on how to overcome some of these challenges, are there other opportunities to do that nationally?
Yes, there are. Think Kidneys have set up a discussion list specifically for people to share their experiences of the algorithm and any difficulties. So this is simply a mail base that you can simply join and email in your query or your experience, and anyone across the UK who is registered on that mail base can respond to that. And that's proved immensely helpful to a lot of people in overcoming some of their difficulties.
So how might a biochemist access this forum?
If you go to the Think Kidneys website, there'll be instructions there on how to find the forum.
So Anne, how does your team alert the clinical teams of positive AKI alerts in UCLH?
Well, when an AKI warning is triggered, it automatically appends a comment into the patient record, and that always flags as abnormal, so that hopefully that makes it easier for someone to spot in the patient's electronic record. We also telephone the AKI warning through to the requesting clinician.
So Anne, from UCLH, you've been alerting primary care for 2 years. What are your experiences of AKI alerting primary care?
I think, as you say, we went ahead with AKI alerting ahead of the national algorithm becoming available. We carried out a recent audit of our GPs, and the vast majority of them found they were aware of the fact that we were issuing AKI warnings. They found them a useful adjunct to patient management, which meant they reviewed the patient clinically more rapidly than they would have otherwise done so, and then either treated them in the community or referred them into hospital if they felt that was necessary.
And what are your experiences of the biochemists in London being willing and able to collaborate on implementing AKI alerts?
Oh, I think the biochemists in London have been terrific and absolutely willing to collaborate and share their experience among the colleagues. Many of them, like us, had gone ahead with implementing AKI warning way ahead of the national algorithm becoming available. So they have a lot of experience to contribute and are always happy to share with their colleagues.